joining us on the line is Dr. Jay Bhattacharya. He's a professor of medicine at Stanford University, research associate at the National Bureau of Economics Research, senior fellow at the Stanford Institute for Economic Policy Research, and at the Stanford Freeman Spogli Institute. And he also directs the Stanford Center on Demography of Health and Aging. He has a piece in the Wall Street Journal over the last couple of days talking about the actual death rates from COVID-19. Dr. Jay, thanks so much for joining the show. Really appreciate it.
My pleasure.
So let's talk about your piece. The initial estimates of the death rate on COVID-19 were extraordinarily high. We heard from the World Health Organization, the same organization that screwed this thing up by believing China when they said there was no human-to-human transmission, say that the death rate on COVID-19 was 3 to 4%, which of course is like Black Plague type stuff. And it's the sort of thing where you start thinking, okay, tens of millions of people are going to die, especially when combined with the infection rate, which apparently is extraordinarily high. You've examined the statistics, and what you say is that the death rate is actually exorbitantly low, or at least exorbitantly low based on the original estimates. How do you come to that conclusion?
So Ben, let me explain a little bit about the scientific uncertainty here, because I think it's really important to understand. So the 3% number and a lot of those high numbers come from something called a case fatality rate. The case fatality rate has a numerator and a denominator. Numerator is the number of people who die from COVID. That's a hard number, very easy to see and measure. The denominator should be the number of people who have been exposed to COVID, got the disease. The problem is that when you measure the number of people who've got the disease, the test people use, and that everyone's used up to now, being like for scientific reasons, there haven't been a good test, an alternate test, is a test that RNA content of to see if you actually have the virus actively in you. But what if you get better? What if you get the COVID and you get better? Well, then the virus is gone, and that test would be negative. So the denominator, and we also use these tests clinically in a way to focus on people who have the disease, are really, really sick, to help guide clinical therapy, or to think, completely reasonably. But if you put those things together, you end up with a denominator that focuses on people who have the virus and ignores the people who got the virus and now have antibodies to it and are probably immune. So what you really want for the death rate is, in the denominator, both of those populations, people who actively have the virus plus people who have the virus and are cleared of it. So that's why I think that it's likely that 3.4% number the World Health Organization now has put out is probably too high. The central key piece of missing scientific information is what's something called the seroprevalence, the proportion of the population that have antibodies to the virus. If we had that number, we could know the true death rate, and we could know how extensively this virus has spread. It's already spread very, very extensively. Oh, I'm sorry. Go ahead.
Oh, no, and you've mentioned also that when it comes to the number of people measured, there's also just the lack of testing generally means that there are tons of people who are walking around who may in fact have it and are asymptomatic, but have not shown up for a test. So we're missing a couple of numbers. We're missing the people who have recovered and have the antibodies, and we're also missing the people who are walking around symptom-free and transmitting this thing, because those people aren't getting tested at all in most places.
Yeah, no, that's exactly right. So both are absolutely sources of error in the denominator of that number. We have to have that denominator for rational policy, because there's two possibilities with the data I've seen, and they produce very radically different, correct optimal policy response. So on the one side, you have a disease that's incredibly deadly, but only relatively few people have it. Then you have an incredible long shutdown to avoid making so that it extends to everybody else. That might be reasonable. On the other hand, you have a disease that's very, very widespread and as deadly like the flu, or maybe less than the flu. Of course, the problem is there's no vaccine, so you can't prevent lots of people from getting it. But on the other hand, a shutdown in that situation is probably less likely to be the right policy response. So you want targeted things where people are vulnerable. You hold them, you quarantine them, or you provide them support. You make sure the hospital systems don't get overwhelmed. It's a very different policy response. The key number that decides between those two scenarios is the seroprevalence in the population. What we desperately need right now is testing of what that number is, and a population level study of antibody testing to find out what the seroprevalence is, to decide between those two scenarios. And so my colleagues and I were trying to work on this.
Well, one of the things that happened today, I don't know if you saw this, is that the UK actually announced that they no longer consider COVID-19 to be a high consequence infectious disease, specifically because they are seeing the death rate is significantly lower than they thought it was. So in your estimate, when we talk about what the actual death rate is based on sort of the incomplete data that we have, are we talking about a disease that is about as deadly as the flu? Is it less deadly than the flu? Is it multiple times more deadly than the flu? What do you think is the range of possibilities here?
I mean, I think my hypothesis is it's less deadly than the flu. I don't know for a fact. It's a hypothesis, and because I don't know the number, I don't know the sero. Once I know the seroprevalence, I can answer that question with a lot of certainty. The people that say that it's 3.4%, they also don't know that number. And they're acting on, people say based on their expertise that I know it's one number or the other. I don't feel comfortable with that because they don't know. There's no scientific study is done and looked at that number. So the question is, how do we respond now? Based on the numbers that I've looked at and based on my analysis, I believe that it's very likely a widespread disease and much less deadly than somewhat less deadly than the flu on average. Although obviously it's killing people, lots of people, and stressing hospital systems around the world. So it's nothing to take lightly. I think the key way to convince people about that is let's do the science. Let's actually conduct a population surveillance. And for that, we're going to need to get rid of lots of hurdles. So like the FDA only the last couple of weeks, or I think last week, maybe a week and a half ago, approved the first antibody test for use in the United States. We need to expand our capacity of antibody tests very, very rapidly and apply them in intelligent ways. The very first use should be to let scientists who want to measure the seroprevalence, let us do it.
Well, with all of this said, Dr. Jay Bhattacharya, professor of medicine at Stanford University, let's say that your hypothesis is correct and the death rate is significantly lower than certainly has been estimated and maybe lower than the flu. So what would that look like in terms of policy? So the sort of going suggestion has been that we needed a mass lockdown in the absence of data so that we could determine exactly what the rates are and so that we didn't overwhelm our healthcare system, because obviously everybody's seen the flattening the curve chart at this point, and the curve being flattened beneath what our healthcare system can actually tolerate would be necessary at this point. We've seen no estimates from the federal or state governments as to how many beds, ICU beds, how many ventilators would be necessary where we feel secure in letting anybody sort of out of isolation at this point, except for extraordinarily vulnerable populations. Number one, do you think that the mass lockdown was the proper policy in the absence of data? Number two, given that the mass lockdown has already taken place, how exactly would you approach alleviation of that lockdown? What steps would you take in the near future in order to get people back to work if it turns out that your hypothesis is correct, that the death rate is significantly lower than expected?
To answer that first question, I guess I don't really have too much time for recriminations at this point. I do think that we should, going forward, think much more carefully about how we make these decisions, because I think to some extent fear led to decisions that have led to the shutdown. I think the shutdown on the other side will have enormous consequences. I mean, I'm looking at unemployment rates that are just on Great Depression level, and I think that the mortality effects of that as well. So I think one of the key things I would like to see reformed is to systematically appreciate the not just the visible consequences of people dying of COVID. It's visible. People reasonably want to do something about that, but also the invisible things that happen later as a result of policy. Because I believe there's likely to be excess deaths, substantial numbers of them among the poor, among the elderly, among lots of vulnerable populations as a result of the depression that I think we're about to hit. But again, that's for a later time. Right now, the key question is what's the seroprevalence, and I think once we know that, then we can start to relieve the shutdown. If it is as high as I believe it's likely to be, we can start to relieve the shutdown. We can also use the testing as a way to see if you can go back to work. My old professor who wrote a really nice piece about this, Alan Garber. What he basically argues is that we can use antibody testing. Say if you're antibody positive, you're probably immune. Go back to work. There's no risk of you from COVID, no risk of spreading it. And so we can end the shutdown right there. Intelligently, by systematically letting people go back to work who were not spreading the disease in any way, shape, or form, and are immune to it already. So I think those kinds of ideas would be really, really useful going forward, so we can sort of balance the epidemiology and the economics in the right way. Because right now, the policy of a complete shutdown is going to have consequences on the other side, and people have characterized it as dollars versus people, deaths, but that's not really right. It's deaths on both sides. If you have an economic depression, people are going to die. So I think that's the right way to start thinking about this. Let's do recriminations later. Right now, let's focus on getting the right number we need, which is the seroprevalence, and then starting to use the antibody testing in a way that intelligently allows us to expand to relieve the shutdown, get our economy going again.
We're speaking with Dr. Jay Bhattacharya, professor of medicine at Stanford University. So I know that we don't want to do recriminations here, Dr. Jay, but when we talk about the lockdown and the entire economy shutdown, one of the suggestions was made by the Imperial College study that suggested that 500,000 people were going to die in the UK. They've now estimated that down to 20,000 or less in the UK over the course of 3 days. The people who are in charge of the study basically suggested the reason for that is, number one, the death rate being lower, but number two, that the lockdown is actually effective at preventing this. If you let people out of the lockdown, it's not going to be 20,000, maybe it's 100,000. There's a study that came out from University of Washington today suggesting that the total number of deaths in the United States over the next 4 months could be 80,000. I'm not sure what death rates they're applying in that study. I've been trying to figure that out all day long here. Do you think that the lockdown and people staying home has been effective in at least reducing the transmission? How many excess deaths have actually been prevented? And I'm not looking for a hard number, but like a lot, some, a few.
I apologize if I can't give you a hard number on this because it's difficult, right? But I think the key thing there is that you can see the uncertainty in practice right in front of you. The argument for the shutdown essentially is to not overwhelm healthcare systems, like as in Italy, as what's happened in Italy. That's actually not unreasonable. I mean, it depends on the capacity of the healthcare system to deal with large numbers of people who need ventilators and ICU beds and things like that. So I think it's hard for me to comment directly. I think I have paid very careful attention to the Imperial College study, and I saw just this morning that Neil Ferguson, the PI for that study, just basically changed his mind. It sounded like, but I have to look more carefully. I think there there you see people putting numbers in the seroprevalence. Essentially, they've assumed a seroprevalence and death rate number initially that led to this massive shutdown policy. But that number isn't justified by an actual study of the population. They guessed that number. I think we scientists need to be much more careful about and more humble, I think, about the confidence with which we say let's do this when we don't actually know a number. We should say we don't know that number, or reflect the uncertainty in our or confidence in our statements much more effectively than we typically do.
And Dr. J, final question for you. Let's assume that we actually do get these tests in place, that we start running all of these seroprevalence tests. That seroprevalence, by the way, just to check my definition of this to make sure I'm getting this right, that would be checking the prevalence of the antibodies in people's blood, basically. Once those tests, once those tests are correct, then how soon do you think this lets up? How soon could we be looking at getting out of home jail here?
I want these tests yesterday. I want them done yesterday. I want the number immediately. And we have studies that I'm working on with some of my colleagues to get in Santa Clara Valley and LA County to get seroprevalence in those counties. But we need a nationwide study, and we need support for a nationwide study immediately. But the two key things that are missing right now is we need a large number of antibody tests, and we need some funding source to pay for that test, and then we can get that running. With the scientific community around the folks I talk with, they want these numbers also. So this is not something that's controversial. I don't think it's partisan. I just think we need the number, and I'm hoping we'll know it in 2 weeks' time at the latest.
Well, really amazing stuff and interesting and vital stuff here from Dr. Jay Bhattacharya, professor of medicine at Stanford. Really appreciate your time, sir, and thanks so much for your hard work on this topic.
Oh, yeah. Thank you, man. It was a real pleasure. Take care.
I hope you enjoyed that clip from The Ben Shapiro Show. If you did, go ahead and hit the subscribe button so you stay up to date on all of our future content.